just a couple of minutes about value and cost, and want to hear from all of you how you define value, because value is really of, what is it worth? Where would you put your money if you were the one deciding how we were going to spend money in our healthcare system? What is it worth to us as a society? What is it worth to you personally? Often things that don't go together in their consistency. I am going to talk primarily from a US-centric point of view because that's what I know best, although I have, as I'm sure many of you do, some familiarity with particularly the steps that have been taken in the UK to try and put value on specific treatments. So there's been a lot of talk about value in the past few years, obviously with the healthcare reform. There have been forums convened by the Institute of Medicine, ASCO has been involved, Sea Change, and a lot of smaller organizations that have really put their thoughts together about what value means. And I'm just going to summarize very briefly what I've taken from participating in some of these meetings, as well as what the literature tells us is how people define value. So a lot of people say, well, the really important value is that, first of all, you have access to care. Again, in this country, we have tens of millions of people who don't have insurance, and they often wind up getting some care, but it can be at a very much later stage and perhaps not the kind of care that you or I would want for ourselves. So access to care is a very important part of value. There are people who say that the most important value, and we hear this now, is really in prevention and early detection, that that's really where we should be putting our resources, because we should be trying to help people avoid getting cancer to start with. Then people will say, well, why all this talk? Obviously, the most important thing in value is to get cured. If you're going to be sick, you want everything done possibly. But that's what my value is I want to be cured. I want to put my money on those interventions. There's some things in the literature that people say, well, there's a lot of value. This is a different kind of issue, more of a systems issue, but I want to be in a system that really has good communication and that I can negotiate and that I can understand how I can work my way through that system, because healthcare is just so incredibly complicated. I want real emphasis put in that, and that's where I want my money put. If you spend any time at this meeting, go to any of the sessions, all the talk we have about palliative care, all the terrible stuff we had politically in this country about death panels. What do we know about pain and symptom management? Is that something where we really should be putting our resources? How much do you value that? And certainly as you talk to people who are dealing with cancer, particularly in a more advanced state, they will tell you how terribly important that is to them, that's where their value is. There's a really interesting article that I read before a presentation I did a little while ago about, it was in the JCO, looking at the stress levels of the bereaved whose relatives had died in an ICU setting, and that their stress level was much, much higher than people who had died in a more controlled setting with more support and better symptom management. So you not only have value on how the person who is sick, but you have value for your survivors. So I do want to talk a little bit about how you all would define a value, both personally and professionally, and how we define this as a society. So then you have cost on the other side. We hear about cost, oh my goodness, multiple times a day. Costs are absolutely and unequivocally a problem. They're definitely a problem in this country because of our fragmented health system, but they're very much a problem every place in the world as drugs get more and more expensive. You go to sessions here and you learn about new drugs that look like they have real impact, and each drug is more expensive than the next, and that's really what we're in. And again, how much is that worth? These new drugs, which really can be changing people's courses, what is it worth? We know with costs that patients are the most vulnerable. Physicians complain about costs, pharmaceutical companies complain about costs, insurers complain about costs, but unequivocally the patient is the one who's most vulnerable because it's his or her life. There's nothing that is more important than that, and that's where cost becomes most significant. We also know the cost has a real disproportionate impact on those who have fewer resources. If you have better resources, you obviously can absorb more of these costs than if you enter this diagnosis with limited resources. And we also do know from evidence that lack of money stands in the way of care at every single level. I had the privilege of participating in the IOM committee several years ago that looked at psychosocial needs, and we did really thorough evidence reviews, and there's everything from prevention through end of life through bereavement, that it's not good to be sick, but it's it's better to have money if you're sick than it's not, because it does stand in the way every single way. Also, when we talk about cost, we can't just talk about the cost of medical care, but all of the unreimbursed costs, the out-of-pocket costs that people spend lots and lots of money on, and whether that's for the insured. We all in this room, I imagine, are insured, but we still know about all of our co-pays and our co-insurance and our deductibles and all of that, as well as things, the totally uncovered costs of things like transportation. There's also some interesting work that's done on the time spent in getting care, an enormous amount of money that's lost in the time that is spent. So cost is mostly a problem for people who are uninsured. Can't be worse off than being uninsured and starting a diagnosis of cancer, where cost becomes prohibitive. But even for those who are insured, it clearly is a cost. It also has a lot of emotional implications. You can have real discrepancies in families of what's worth it for whom, and it's very hard when you start a diagnosis. I bet very few of us have had experience with people who ask, how much is this going to cost in the long run, because you can't predict the long run. So cost has all of the psychosocial implications as well as the real implications. So I just want to give you a couple examples of this kind of bind between value of cost and then hear from you. So these are real world situations. A woman who I had contact with at one point who had a 7-year-old who had a brain tumor and 2 younger children. The child with the brain tumor had been treated for an extended period of time. And the family, both parents worked. They were people we would consider, they were middle class, educated people who lived pretty well. Mother had to stop working because the child was sick. The family wound up borrowing lots of money. They went into all of their retirement funds. They eventually did in fact declare bankruptcy. And half of the bankruptcies in the United States are related to healthcare costs, and among healthcare costs, cancer is the highest. So what is this family to do? And I think that they would say very clearly, and we would all say too, that this was their child, and there was absolutely no question about value versus cost. They were going to do absolutely everything, no matter what it cost, because it was their child. In contrast to that is another woman with whom I'd had some contact, whose husband had had a metastatic colon cancer, had been sick for quite a while. He was 63. He'd been prescribed a drug that had a very large copay that was really going to be very difficult for the family to absorb, and he didn't want it. He said he'd had it, that this was just too much. He'd been through enough, and that this was just too much cost to take on, emotional cost, financial cost, every kind of cost. And the wife outside of him was trying to seek help for these copays. So this is where she thought it was absolutely worth, no matter what they had to do. But for him, when you talked about value versus cost, he didn't think that it was really going to be worth it. And then a more typical situation of someone that's not so extreme, but we hear about all the time. There's just data yesterday about a new aromatase inhibitor with good data attached to it. These are outpatient drugs. We still have the donut hole for people who have Medicare. We still have people who have lousy outpatient insurance. And probably those of you who work in breast cancer have lots of experience with people who part of the way through the year run out of, start to have to pay for this themselves. And we know that there's lack of compliance with these drugs, most of which are prescribed for 5 years, for a whole variety of reasons, but a major reason for this lack of compliance is because of the cost issue. So what's it worth to somebody to take this drug that they're being told that will reduce the recurrence, when perhaps they're really building up very big bills? So just 3 short vignettes of kind of this bind, and how do you reconcile this? How do we reconcile this as a society? How do we reconcile this in our organizations and at a personal level?
I had a chance to interview Dr. Thomas Smith, one of our nation's prominent palliative care experts, and we got into a discussion about culture, especially this American culture, and our comfort level or lack of with the D word. And because death and dying is something that seems to be so taboo here, that we fight very hard to hang on to life without really being able to integrate the fact that dying is a natural part of life. And someone who's a trained social worker, it would also be interesting to hear how much of our attitude culturally about death influences our choices of the way we perceive value and cost.
End-of-life care is a major issue with cost because the amount of money that is spent on the end-of-life is an enormous proportion to the rest, but it is very, very influenced by cultural perception. And I talked to Tom Smith. He actually had an article in the New England Journal last week about costs in cancer and 5 different things that the oncologist and the patient could do to try and reduce costs. And I bumped into him in the hall, and he said he's already gotten a few of the the hate calls and the death panels,
right,
and the how can you talk about restraining care for anybody at that point? So we not only have something that's difficult for people personally, but we do have this societal perspective.
And it needs to be really a part of the dialogue that patients have with their medical oncologists. And we also spoke about the fact that if medical oncologists are not able to talk about dying with their patients, because they're human beings that bring their whole life history into their practice and their own comfort level. And the worst part of what I've seen is when a patient is in the final stages of life where the medical oncologist retreats and isn't around for that patient.
Yeah. Many, many physicians will tell you very forthrightly that it's a lot easier to give another drug than it is to engage in a talk about the fact that somebody is going to die. And it's hard on, nobody wants to talk about that. It's hard on all sides. So we can't say, oh, it's the doctor's fault, because it's just easier. And that's part of the dynamic. But I do want to hear from some of you about what you think about this idea, this concept of value. And of course, NICE measures value very specifically with their qualities, and but what do you think? How would you define value? What do you hear from people that's important to them?
My name is Linda House. I'm the Executive Director of St. Vincent CancerCare in Indianapolis, and a number of you have heard me comment on this topic, whether it was in my former role or in this current role. But when I graduated from nursing school in 1984, they taught us the 5 rights, and it was right patient, right drug, right dose, right time, and right route. And I really think about our current environment and the incentives and really how we're working and being flexible enough to go back to the roots of those 5 rights. So when you're looking at, are we giving the right drug, and thinking about personalized medicine and really incentivizing or disincentivizing the development of true personalized medicine and calling it what it is. So we're really looking at individual targets. When you're looking at physicians, being able to give the right route. So you look at insurance companies and being able to get reimbursed for the right route, whether that's an oral agent or an IV agent, whatever that looks like. And I won't go through each of those individually, but how do you really take a look at back to the roots of those 5 rights and be flexible enough to treat patients in that way?
That was a really, really interesting set of points that you made. And we lose sight of value. And the problem that I have is that I still function as a physician, seeing an individual patient sitting across the desk, so I have that relationship to manage. But there's also the population value in that in difficult times, when money is tight, when costs are rising all the time, how do we manage value in a system of a socialised healthcare system like ours? And what we're looking at is to try to disinvest in expensive therapeutic interventions which are of low, aren't worth very much. We do a lot of stuff that's quite expensive, that doesn't really add much health or quality of life or improve things. And part of us is trying to think through how we would reinvest that in what a greater added value would be. And the way that we do that is that we have something called NICE, the National Institute for Clinical Excellence, or cost effectiveness, in which we make value judgments based on how much a new treatment will add life to quality of life and length of life, and what the cost of that in real terms will be in terms of dollars to our healthcare system. And again, we work that modelling through very carefully indeed, with patients, with carers, and the debate that you've just initiated, we've tried to have, so that we actually have to set a dollar value and how much we move things forward in that way. Somehow that was translated in a series of really ghastly television ads into the death list stuff. I've never seen such crazy shroud waving.
The culture of this country makes something like NICE difficult. I mean, there is something in the healthcare reform thing that is a panel that is going to decide on, what should be reimbursed by Medicare, and there's enormous pushback to it. So again, this kind of individualistic strain that there should always be the agreement between the patient and the physician of what is best for that particular patient without a third person. But again, we have an unsustainable situation, and there's nothing like this meeting that brings that home, where you hear about drug after drug after drug, some of which do great things, some of which do teeny tiny little things. So what do we do? Everyone here talks to people who have cancer, real people, many of whom want to do everything. What is our, how do we respond to that?
I think lessening the burden with respect to pain management. One particular symptom that our patients experience that's incredibly painful for them is itch. They have chronic itch a lot. Yeah. And what they relay a lot of times is that, I've accepted that I have a cancer diagnosis. A lot of times it's indolent, it's slow growing, but they have this chronic itch. And so they will do anything, to find something to at least get rid of the itch. So I think pain management, just of the itch itself would be extraordinary. So there are actually some drugs coming to market soon. We hope that will really help with that. And another really important value, I think, that comes across in communication from our patients is the relationship with their healthcare team, their doctor, their nurse. There are dramatic differences, that are shared. We have a listserv where patients communicate with one another, and there are dramatic differences between Dr. A and Dr. B, and they'll share that. Patient A has an excellent communication, good relationship and communication with their doctor, and patient B doesn't. And so they will share that, and they will talk about how emotionally, that makes such a difference to them, that they can talk openly and have a good relationship and rapport and openness, ability to ask questions and feel comfortable with their doctor. So I think that is something that should be really factored in to adding value, to a patient and physician relationship.
I think the challenge we're facing now with the more and more personalized therapies is we're having a smaller and smaller subset. However, they can have really outstanding response, but in a very small subset of people. So where I have trouble is when NICE says, because it's too small of a subset of people, even though they're going to benefit massively, we're still not going to allow that drug for that small subset of people. And then they have no access to a drug that is very, very likely to give them an extraordinary response, at least for a significant period of time.
Talk about value. How much is it worth to me to live 3 weeks, 3 months, 3 years? It's individual value has a tremendous impact.
And individuality comes out again, and it's a balance of the individual versus a population, and how we make societal needs, and how, in terms of how funding is just now, all of us are being forced to think at the societal level too. And is it worth $100,000 for a drug? Not for the drugs. We're not having an argument of drugs that have a very demonstrably major effect, but it's the marginal effects. And is an extra month of life worth $100,000? I don't know.
Just this last week had this conversation with a doctor whose wife died of ovarian cancer and kept driving hundreds of miles back to Boston to a major medical center. And he has had such a hard time because everyone said, why did you as a doctor let her do that? And she wouldn't take hospice because she knew her husband could do everything that could be done in terms of whatever she needed. And the reality was, he said she had a grandchild coming in a month and she didn't want to give up. And he talked with the doctors about stopping treatment. And she was fearful that people would think she had given up. And she was not ready to not see that. How would people perceive that? But I think we also often talk about people as if they're cancer patients and not us. But here we have a world full of doctors and people. And to me, what was so striking was he was a well-educated doctor. And in his own world, he's now suffering because people are saying, why didn't you help her end this? And yet he was a human, not just the doctor.
Exactly. So well-educated doctor, but husband. And therefore that makes a point. However, continuing needless toxic chemotherapy is not a psychological crutch. It's not, and it cannot be, and it couldn't have been what was right for his wife. And there had to have been a way of intervening in some collective way with the right sort of psychological support to say, look, we're hurting you, it's crazy. we're abbreviating life, not prolonging it. And this isn't the crutch that's going to allow you to see the birth of a much cherished grandchild and so on.
I would encourage you, since this is an ongoing initiative now, we're taking this on the road. We're doing more and more AIAs, not only in the US, but in Europe. One of the ideas that we've had was to hold some kind of communications, basically a summit, for the advocates from the US and in Europe to sit down at a round table and begin to hash out these issues and try to form some kind of a cohesive entity that we can partner on a global level. One, I want to thank all of you, and really this panel, because this could not be done without the expertise of individuals who are extremely well-versed. I hope you have a very successful rest of your ASCO meeting. Thank you very much.
Thank you, Selma.